Now here I just wanted to highlight this line that the agreement between HbA1c and fasting PB and HbA1c and OGTT is only about 20 to 30%. This is one thing which we need to remember and understand, that we are seeing these three tests as independent tests. Though they are associated for glycemia, they are not actually correlating directly. So there is a bit of discordance between these tests when we are analyzing these patients. These are the criteria where one would screen asymptomatic adults for diabetes, and I'm sure all of you know that, but I'll just go through the same. So first degree relative with diabetes, high risk, we are already in the high risk as Asians. Then women with GDM, hypertensive patients, those who have a sedentary lifestyle, a high BMI, then women with polycystic ovary syndrome, previous impaired glucose tolerance and other clinical conditions associated with insulin resistance, and a history of cardiovascular disease. So all the cardiac patients who come to you, all the hypertensive and post-bypass patients also need a screening for diabetes, because diabetes is considered as a cardiac risk factor also. What about children? Children also need screening, asymptomatic children. If they are overweight, if they have any of these two risk factors, whether they have a family history of diabetes, race, signs of insulin resistance, maternal history of diabetes or gestational diabetes. So I think in Indian scenario, most of our children would require screening if they are on the obese side. So that kind of a screening criteria, it exists. Then you come off for the other sect of the population, where you have to classify what type of diabetes the patient is suffering from. So this is a classification of diabetes that we use for our practice so that treatment can be guided. So we have commonly the type 1, type 2, gestational diabetes, and then the secondary types of diabetes. So, and there is an entity called as latent autoimmune diabetes of adult, which we are seeing very commonly these days. It's a young adult coming with a picture like a type 1, in the sense they are insulin requiring, they are autoimmune in nature, they have antibody positive status. So these adults usually they have age of onset before 50, they have acute symptoms, they have osmotic symptoms, they have a low BMI or average BMI, and they have a personal or family history of autoimmune disease. Now these are patients whom we need to actually pick up with proper diagnostic criteria, and they are most confused. Believe me, they want to be on tablets, they are not ready to take insulin, and they are not ready to accept that they may be requiring insulin for treatment. Now again, the differentiation clinically is very difficult. So the clinical presentation of type 1 can come like type 2 and vice versa. And occasionally patient with type 2 may come with ketoacidosis, and sometimes a type 1 diabetes may have a recovery and a slow onset phase. So it is very difficult for me to answer this question as to which type of diabetes I am suffering from. So some lab tests might be beneficial there. So we have the C-peptide, the antibodies, the GAD antibodies, the islet cell antibodies, and insulin autoantibodies. And then you have lipase and amylase as markers of pancreatic function. So these are the gross diabetic status, which if those tests are positive can confirm that these are the possible diagnosis. If they are negative, they may not rule out. So it is worth doing this. So type 2 diabetes, usually the C-peptide is in the normal or the higher normal range. Antibodies are negative, amylase lipase is normal. Type 1, you'll have a low C-peptide, a positive antibody status, normal lipase amylase. Pancreatic diabetes, you'll have a low C-peptide, negative antibodies, raised amylase. And in LADA, you may have everything like a type 1 diabetes, and that is the case where you can actually think that this patient may be having autoimmune diabetes. So this can be the only role, and it may not be the confirmatory role. So negative test doesn't rule out anything, but positive, yes, it would give you some clue. Then coming to gestational diabetes, again I said that this has a lot of gray and zone into it, but I'll try and clarify from the clinician's perspective. So by definition, it is any grade of glucose intolerance first time during pregnancy. The classification, again, what we prefer to use is a pre-gestational diabetes and a gestational diabetes. Now this is what we are seeing very commonly these days. So patient is already a case of diabetes and has come with pregnancy, or the patient has been diagnosed with pregnancy with diabetes immediately in the first month of pregnancy. So that is the scenario where we are treating these patients like a pre-gestational diabetes. Now here there comes a role of preconceptional checkups and evaluation of these patients. So most of these patients who satisfy the risk criteria or they are known diabetic, they need to be evaluated pre-pregnancy for a preconceptional counseling. Then comes gestational diabetes per se. Now gestational diabetes is a recurring disease. So every pregnancy the patient might have gestational diabetes, and then you have either previous gestational diabetes, previous impaired glucose tolerance of pregnancy on oral glucose tolerance test. So this is the kind, so any patient who has had gestational diabetes needs a keen follow-up during subsequent period and pregnancy. Now initially we followed this one-step and two-step approach. So now this is what I've put up. I don't want to confuse the issues a lot, but commonly the current guidelines by WHO, by DIPSI, they say that if you want to screen with a single test, you do a 2 hours post 75 gram glucose and see what is the blood glucose. And if this single step 2 hours postprandial 75 gram GCT single step is more than 140, you think that this patient, this is a screening test, you think and you confirm that this patient has diabetes on a second occasion. So it is both a screening and a diagnostic procedure. You should not be starting treatment on that report, you need a confirmation, but this nevertheless will help the patient to be diagnosed in one go. So this is what DIPSI is recommending currently, but initially there are still many gynecologists and many pathologists who are following the 50 gram GCT and 100 gram GCT. So if you are following any of those, you need to understand the guidelines. So initial GCT with 50 gram glucose, the advantage is it can be done in the OPD scenario. And there if you have a blood glucose more than 140, you're picking up about 80% of GDMs. If you're having more than 130, you're picking up about 90%. And there have been lot of studies which show that any blood glucose in a pregnant lady between 120 to 130 is bad enough to cause problems in the fetus eventually. So for all practical purposes, any blood glucose above 120 needs to have a raise of antenna in terms of possibility of gestational diabetes. Now here when you are doing the 50 gram, you definitely need a 75 gram OGTT for confirmation. If you are using this DIPSI guideline and you are doing a fasting patient, you are doing a 2 hours postprandial glucose of 2 hours and you are finding 140, it is actually confirmatory. If the patient is not fasting, then you need a repetition. So this can be done on a OPD scenario as well as in the fasting state. Now when to test is a second question. It depends on the risk stratification. Now as I said, we fall into the high risk population, but nevertheless if you have those high risk criteria, you should be doing it at the first antenatal visit itself. So there is no time for that. First time patient comes to you, you should be doing the test. Now these are certain low risk where you need not do. If you find anything like a low risk into your practice, there may be a possibility that you don't want to do it, and that is up to your preview. So in a low risk in a low risk you need not screen. In an average risk patient, so where you have less of risk factors, you do it at 24 to 28 weeks with 1 or 2 step approach as per your convenience. And high risk patient, you do it at the time of the first antenatal visit, and if it is negative, you repeat it at 7 months, so at 24 to 28 weeks. So considering that our population is high risk, we usually do it at the first antenatal visit and again at 24 to 28 weeks.